So today we're going to tackle fluid volume excess, FVE for short. It's that sneaky situation where there's just too much fluid hanging around in the body. Can get serious, fast. Our mission, really understand it like we're study buddies, figuring out the why and the what to do.
Exactly. Think of it like your body's plumbing system is overwhelmed. Too much coming in, not enough going out, or maybe both. It's fundamentally an intake-output problem.
Yeah.
We want to make the pathophysiology, the how it works part and the nursing plan really clear.
Okay, so where does all this extra fluid actually come from? It's not just about guzzling water, right?
Right. Not usually that simple. Big culprits are things like way too much salt in the diet, sometimes medications like long-term steroids.
Corticosteroids.
Yeah. And then the big ones. Chronic diseases. We're talking heart failure, kidney disease, liver disease, even Cushing syndrome can play a role.
So those underlying conditions are really key drivers.
Definitely. Especially the kidneys. If they aren't filtering right, the body holds on to water and sodium. It's like the off switch is broken.
Gotcha. And I know some groups are more at risk. You mentioned infants and older adults. Why them specifically?
Yeah, it's tricky at both ends of the lifespan. Infants, well, they're mostly water to begin with, percentage-wise, so even a little bit of extra fluid can tip them into overload really fast. The margin for error is tiny.
Wow, okay. Small volumes, big impact.
Exactly. And for the elderly, their kidneys might already be slowing down, plus they often have those chronic conditions we just talked about. So FEE hits them harder, increases mortality risk quite a bit.
Makes sense. All right, let's paint the picture. What does FEE actually look like in a patient? What are the signs? I know one thing always stands out in the textbooks.
You mean the weight gain?
Yes, that rapid weight gain. That's like the big flashing NCLEX alert sign, isn't it?
Yeah.
Why is that the number one thing?
Because it's the most direct measure of that extra fluid just sitting there. It's objective. You can't argue with the scale showing, 5-7 pounds gained overnight.
Okay, undeniable proof. And where else does this fluid show up, like visually?
Well, check the neck. You'll often see jugular vein distension, or JVD. The neck veins look like they're bulging out.
Because the whole system's backed up, like traffic jam.
Pretty much. And you'll feel it, too, a bounding pulse, like it's really forceful, and the blood pressure will probably be up.
And then the breathing. That's often where things get scary, right?
Absolutely. The lungs are a prime spot for that fluid to collect. So you listen, and you hear crackles. That's literally the sound of fluid in the air sacs.
Crackles.
Yeah.
Like wet sponges.
Kind of, yeah. And the patient will likely be breathing fast, tachypnea, trying to compensate. This can happen fast, especially if their heart's already weak. You can go from a bit puffy to full-on pulmonary edema, sometimes in just a few hours.
Just hours. Wow. Okay,
Oh.
so the body is overloaded. Now, the labs, this part can be a bit confusing. If there's more fluid, wouldn't you expect things in the blood to be, like, more concentrated?
See, that's the paradox. It's the opposite. All that extra water dilutes everything in the bloodstream. It's a hemodilution effect.
Okay, dilution. So what lab values drop? What are the NCLEX alerts here?
You're looking for decreased values. Lower BUN, that's blood urea nitrogen. Hematocrit goes down, think less than 42% for males, 37% for females, roughly.
Because it's watered down.
Exactly. And crucially, sodium Na plus Su drops below 135 milli-AuQDL. That's a big one because low sodium messes with the brain.
The neurological connection. Confusion, maybe even seizures if it gets bad.
Yep, that's the risk. And urine-specific gravity will be low too, less than 1.005 because the kidneys are trying to dump pure water if they can.
Okay, so low BUN, low hematocrit, low sodium, low specific gravity. Got it. Now let's shift to fixing it. The nursing action plan. What's the strategy?
The goals are pretty clear. Get the extra fluid off, stop more from accumulating, and fix the underlying problem if possible. So treatments usually involve diuretics meds to make you pee more.
Water pills.
Right. Plus, restricting fluids, telling the patient exactly how much they can drink, and restricting sodium, so less salt in the diet.
Makes sense. And in terms of what nurses do, the implementation part, what are the absolute must-dos?
Two things are non-negotiable. Strict INOs, meaning intake and output. You track every single milliliter that goes in and comes out.
Okay.
Every single. Drop
Meticulous tracking.
Absolutely. And daily weights, same time, same scale, same clothes every morning. That weight trend is your best friend for monitoring if the treatment is working. It's the most consistent indicator.
Okay, INOs and daily weights. Burn those into memory. What about keeping the patient safe while all this is happening? They're swollen, maybe confused.
Good point. Safety is huge. All that edema makes the skin fragile, so meticulous skincare is vital to prevent breakdown. Positioning is important too, like elevating legs if needed or sitting them up to help with breathing. And falls.
Definitely a fall risk, especially if they're weak or confused from low sodium or just feeling unwell. So full precautions are a must. It's also about helping the patient understand why they need to stick to the fluid and salt limits. Adherence is key.
Right, patient education. So after we've done all this, the diuretics, the restrictions, the monitoring, the safety checks, how do we know if it worked? The evaluation step.
You go back to the goals.
Hmm.
Is the patient's fluid balance better? Check the weight, the INOs, the edema, the lung sounds. Are they free from complications like skin breakdown or falls? Did they understand and follow the plan?
And if things aren't quite right,
Then you reassess, figure out what needs tweaking. And this is where teamwork shines. You're collaborating with the provider, with dietary about the low sodium meals, maybe with PTOT, physical and occupational therapy to help with mobility safely.
great point about the team effort. Okay, let's recap the big takeaways. Fluid volume excess. Think overload. Key sign.
Weight gain, rapid weight gain,
Labs will look.
diluted, low BUN, low hematocrit, low sodium.
And the core nursing actions. Strict INOs and daily weights, plus safety skin, positioning, falls.
Awesome. The overall goal is always getting back to and staying in fluid balance.
Precisely. Now, to leave you with something to chew on, we talked about infants and the elderly being high risk. Think about this. How does their ability or sometimes inability to clearly tell you their symptoms change how you prioritize your assessment, especially in that critical window where things can worsen so quickly?
That's a really practical, important question. How do you assess someone who can't easily say, I feel short of breath or my head hurts? Definitely something to ponder. Keep that in mind as you continue learning. Thanks for joining us on the Deep Dive, and we'll catch you next time.